This is Dr. Kriti Mehra from St. Vincent Hospital, and I'd like to thank you for considering my submission for a poster presentation. I'm here to talk about my abstract titled For CRAO-ing Out Loud. COVID is an inflammatory state that leads to a procoagulant environment. This has been seen mostly in the form of venous thrombosis, manifesting as DVTs or PEs. Lately, arterial thrombosis in the form of strokes or myocardial infarction have also been noted. Central retinal artery occlusion or CRAO is a rare presentation of thrombosis in COVID. So when we saw a case of CRAO in COVID, it certainly caught our attention and we decided to raise a hue and cry against it. Our patient is a 49-year-old male with a history of sarcoidosis, not on any current treatment, who presented with painless loss of vision of the left eye for 1 day. 2 weeks prior to this, he tested positive for coronavirus and did not require hospitalization. His vision loss was sudden, not associated with headaches, and progressively worsened over the course of the day. He then visited his ophthalmologist, who found a cherry red macular spot on fundoscopy, and he was immediately referred to our emergency department. His visual acuity was 20 by 25 in his right eye and finger counting at 3 feet on his left. Basic labs, including CBC BMP coagulation studies and inflammatory markers, were unremarkable. Antiphospholipid antibodies were sent as a workup for antiphospholipid antibody syndrome, or APLA, and these were slightly above normal limits. CRAO was then confirmed on fluorescein angiography. A stroke workup, including CT angiography and echocardiogram to look at intracardiac sources of emboli, was negative, and patient was anticoagulated with the apixaban. A repeat testing of antiphospholipid antibodies 12 weeks later ruled out APLA. Patient was diagnosed with CRAO secondary to COVID-19 and was treated with the apixaban with an intention to treat for 3 to 6 months, as this was a provoked event. COVID-19 predisposes to an increased thrombogenic state by affecting all 3 components of Workhouse triad. Increased von Willebrand factor, endothelial dysfunction, and tissue factor pathway activation contribute to this thrombogenicity. You add cytokines to this recipe and you've got yourself a fresh batch of clots. ACE2 receptors have been implicated in extending a hand towards coronavirus and inviting it in. Retinal tissue is known to express these receptors. COVID-19 patients have decreased ACE2 function directly following the binding with coronavirus, and this depletion of ACE2 receptors could upregulate pro-inflammatory stimuli as seen in animal models. Our patient also had transient antiphospholipid antibodies. By definition, these antibodies should be elevated on 2 separate occasions to diagnose APLA, and their titer should be moderate or high. Our patient's antibodies were only slightly elevated, and they were elevated on only 1 such occasion. Hence, APLA was ruled out. But transient development of these antibodies could also contribute to the prothrombogenic state. Our patient also had a history of pulmonary sarcoidosis but was asymptomatic, and this was an unlikely contributor to his presentation. CRAO is an ocular emergency and requires immediate evaluation. Thrombolysis is an option in patients who present within a 24-hour period. Hence, it is essential to identify CRAO as a thrombotic manifestation of COVID. Thank you.